All right, so hello and welcome everybody. So this is the first session of the Neuromodulation Day, and we will start with a basic introduction into brain stimulation applications and also how to combine that with tractography to better understand functional connectivity in the brain. So why do we need brain stimulation? Basically to identify brain functions, so for functional brain mapping and for connectivity measures. So for example, we have electrical cortical stimulation, where we apply electrical stimulation of approximately 50 Hertz with around 5 to 10 milliamperes in a, let's say, bipolar manner. And then during the stimulation of 2 to 5 seconds, the behavior can be altered. So we will have a symptom, for example, blocking speech, like aphasia, or we can execute motor functions, or we can also inhibit ongoing motor movement, and by that better understand how the cortex can be characterized into functional brain regions. On the other hand, we can also stimulate into the brain and measure evoked potentials. So when we stimulate with a single pulse, then we can measure on distant locations in the brain how the brain reacts to that electrical stimulation pulse. This is called cortically evoked potential. And here we can see how different areas in the brain are connected with the stimulation region. Then also we can stimulate, for example, peripheral nerves like the median nerve and measure evoked responses on the cortex that are related to the motor pathway. This is also a good marker, for example, for brain surgery guidance to identify the central sulcus at the beginning of a surgery. So this is mainly to localize brain activation and active regions. And on the other hand, we can also utilize brain stimulation for actual treatment of disorders. So for example, famous is of course the deep brain stimulation for tremor and Parkinson's patients, where if you stimulate the subthalamus nucleus, then you can actually inhibit the shivering of the hand or stop the tremor. Then it's also possible, for example, to have vagus nerve stimulation. This is a peripheral nerve where you can suppress or reduce the number of seizures in epilepsy. And then also, for example, another application is responsive neurostimulation, where you can stimulate into the epilepsy hotspot, so the foci, and by that terminate seizures when they are detected. So all of that can be classified or categorized into open and closed loop neuromodulation applications. And in the first session today, we will mainly focus on the open loop electrical cortical stimulation and the CCEPs. And later on today, you will see also a lot of applications for closed loop neuromodulation and so on. So let's start with the idea of the functional brain mapping. So in principle, there are different modalities how to localize brain activation or functional regions in the brain. And of course, the most commonly used is the functional MRI, simply because it's non-invasive and you can do it in hospitals prior to a brain surgery or during a diagnosis and other indications. Also, many neuroscience experiments are done with fMRI. And here you will get the differential map from two conditions, a resting and an active condition. And this is a hemodynamic marker. It shows us the blood oxygen level dependency, so how much oxygen is actually consumed in the tissue, and then measured with the deoxygenized hemoglobin amount. This is a hemodynamic marker, so it's more related to the perfusion. But there are also electrophysiological markers, so for example, intracranial EEG or surface EEG and MEG, where we can measure brain activity directly. And all of these methods have in common that they are observational. So they will tell us, based on the task or a condition in which the patient is, we can then assign functions that giving us a biomarker that localizes some changes. Then on the other hand, we have the electrical cortical stimulation, and here we have inhibitory and excitatory effects actually in parallel. So for example, for the language, when you talk and you get stimulated, you might lose the ability to talk, or you get interrupted during the speech. This is called aphasia or speech arrest, and this can be achieved when stimulating the language area in the brain. Also, it's possible, for example, when you do transcranial magnetic stimulation, so this has a similar effect, and also when you, for example, apply the WADA test, so here you're injecting anesthetic drug into one hemisphere, via the arteria, and then you will see the dominant hemisphere, for example, if the patient is not able to talk anymore when sedating the left hemisphere in most of the cases. Then there are also phenomena, for example, when you stimulate the motor cortex, that some movements will occur because of the stimulation. So this is an excitatory effect. And you can achieve this again with the electrical stimulation or with the TMS. And important to understand is that with this inhibitory and excitatory effects, we get very valuable information, especially for planning or during a surgery when we have to remove tissue from the brain, like a tumor or an epilepsy focus. So when we here see which parts of the brain, when stimulated, are blocking a task or a body function, then we will see which parts are necessary to preserve during a surgery. This is very important, and that's why the electrical stimulation is also the gold standard for functional mapping, for example, for intraoperative decision making. So how does this now work? So we have a resting condition, and then stimulate for 2 to 5 seconds with a 50 Hertz strain. So this is also called the Penfield method, and then we will see, for example, the patient will see a visual illusion. Here, auditory illusions or induced speech, have perception on the oral parts, or hand contraction, finger movement, leg movement, or also a sensation in the fingers. And then after the stimulation, this symptom, this state reverts to the resting, and the symptom is gone. And then we know that the symptom that the patient experienced is only caused by the electrical stimulation, and now we can assign this functional category based on the stimulation symptom. For the inhibition, it works a bit different. So for the inhibition, the patient is not in a resting state, but doing a baseline task. And here, for example, the patient is performing a verb generation, picture naming, or simply a communication task. And then during the stimulation, again of a few seconds, this task will be interrupted. And then afterwards, the patient is able, for example, to speak again. So by that, we again understand what is the functional region associated to this speech interruption. And based on the responses, we can now step by step stimulate the whole cortex that is exposed in the craniotomy, for example, or covered by the implanted electrodes, and then create a functional map. And this can be used in the bedside case. So for example, in the epilepsy monitoring unit, when you have electrodes implanted for, let's say, 1 or 2 weeks, then during the time of the monitoring, seizures will be measured and localized. And after this monitoring part, also it's important to conduct functional brain mapping, to have a pathological map and a physiological map. With that stimulation protocols, it's also possible to conduct the functional mapping at the bedside after the monitoring, or for example with a handheld probe that looks like a ball peen pen, and with that you can touch the cortex or even the white matter and stimulate the brain doing an awake surgery. So for that the patient has to be awake, and then you can observe the stimulation related symptoms. So what do we have to do in terms of the stimulation parameters? So the default way to stimulate is a biphasic pulse with a rectangular shape. So biphasic means that you're starting, for example, with a positive phase where you set a constant current of 2 to 50 milliamperes. So usually for motor function, it's in the range of 4 to 6 milliamperes. For language, it might be a bit higher, 8 to 12 milliamperes. And then you inject charge actually into the tissue, and with the negative phase of the biphasic current or the biphasic pulse, you're neutralizing this effect again. So at the end you have a net zero charge after the stimulation, but during the stimulation you're injecting a charge into a volume of tissue and then returning that. And usually a stimulation duration is about 300 to 500 microseconds positive and then negative stimulation. And this stimulation pulse is repeated like every 20 milliseconds. And with this, you have a very strong behavioral response or symptom related to the stimulation. So there are some language protocols where you even go to 200 to 500 hertz, but the majority of the symptomatic stimulation is done in this region. Also interestingly, the risk to elicit a seizure because of the stimulation is also very strong in this 50 to 60 hertz frequency range. Right, and the stimulation, of course, should not be too long. So usually you stimulate for the necessary time to observe the symptom, like 2 to 5 seconds, and then stop the stimulation train again. And as there's a risk of inducing a seizure, a standard protocol is to start with a relatively low current, like 1 milliampere, and then increase, for example, when you start with the motor cortex, increase the current until you observe a movement of fingers or hand, which might be at between 4 to 6 milliamperes. And then if you have a symptom, you have kind of a baseline current that is good for further mapping. Or if you observe, for example, after discharges, then these are an indicator. So during the stimulation, you have a stimulation artifact, and then maybe after the stimulation, you have some discharge events, which is like a sharp and a long wave. And with that, you get an indicator that you're very close to elicit a seizure, so you should not increase the current further. In terms of the safety, it's important that the charge that we inject is not too high, because otherwise we can kill the neural tissue or at least damage it. And the most important safety parameter that we can set is the charge density per phase. So you have to understand that, of course, the phase duration and the current, they are building a rectangle, and the area of the rectangle is the absolute charge. So let's see, if you stimulate 50 milliamperes for 1 millisecond, you would get 15 microcoulomb that you put into the tissue. And now the critical aspect is how big is the electrode that is in contact with the tissue. If you have a very tiny electrode, then all this charge goes into a very small volume. If you have a big electrode, then the charge will be spread in a much wider area. So therefore we have to compute the charge density per phase, and usually a charge density of 50 microcoulombs per square centimeter would be considered as safe for even chronic stimulation. And then the shorter the stimulation protocol is, the higher the charge density can be. So usually you can go up to 150 microcoulomb per square centimeter, where you would experience stimulation damage for long-term stimulation. And if you are staying below 10 seconds, then for a short time, you can also go beyond 300 microcoulomb per square centimeter. And another aspect is, of course, the shape of the stimulation waveform. So we are stimulating with biphasic pulses here, so we have net balanced with zero charge. And if you, for example, do a very long-lasting monophasic stimulation, like only adding up the charge but not returning it, then you can have also some kind of DC stimulation effects and damage the tissue through electrolysis. There are other safety aspects which are more to thermal injury and skin burn, which we usually don't experience with the brain stimulation devices, because if we are capping at 50 milliamperes, we will not reach usually the 10 milliamperes per square millimeter or 20 milliamperes per square millimeter RMS. This would only be the case for very, very tiny electrodes, but usually there the impedance is so high that we cannot go with the stimulation voltage far enough to make a damage. So to give you an understanding what the charge density means, if you understand or imagine a 300 microseconds phase duration, then if we see here different sizes of electrodes, so Unique is a Japanese manufacturer, Inomate a German, Natus American, g.tec American, Cortec German, PMT American. So there are different manufacturers for electrodes like handheld probes and stereo G and grids. And here you can see, for example, the diameter that is exposed and in touch with the tissue. And this will give you an area. And based on that area, we can then measure the charge density per phase. And here you can see for different electrodes, if it's green, then we can do no problem long-term stimulation. In yellow is the transition from long to short-term stimulation, and the bright red can be only do for short-term stimulation less than 10 seconds. So for example, with 1.5 millimeter electrodes, we can do stimulation until 15 milliamperes with no problem. If we now increase the phase duration, so the area of the pulse gets bigger, then we are seeing here an area where we should not or cannot, by the device settings, stimulate anymore. So this is already prohibited and blocked by at least our stimulator to continue the stimulation. So with this, you're sure that you're good and safe. And we have this safety concept in the g.tec Pro. So this is an FDA cleared and CE certified electrical stimulator to stimulate the brain. So especially for electrical cortical stimulation, but you can do it, for example, stimulating via a grid, or also with stereo G or with a handheld probe. So there are different use cases to stimulate the brain. All of them have in common that you can stimulate until 15 milliamperes. Usually for the symptomatic stimulation you utilize up to 100 Hertz. For some clinical research application it's also possible to enable 500 Hertz stimulation, and the maximum stimulation phase duration is 1 milliseconds positive and 1 milliseconds negative, and you can set monophasic, biphasic stimulation and alternating and steady polarity. For the polarity, I will come to that later. That is also a very powerful feature to switch the positive and the negative polarity, to start with a positive phase and then the next pulse start with a negative phase, because by that you can cancel out a bias towards the responses due to the electrical stimulation artifact. So these are the indications, either stimulating via a grid, of course also stereo G, or with a handheld probe like a ball pen. And then you select here, for example, on the motor cortex, you select here stimulation electrodes. Usually those are paired, like one for the stim plus and stim minus, the anode and cathode. And then you can inject 4 milliamperes here and observe how the behavior of the patient changes. So here, for example, in this case, the patient is now performing a baseline movement, and while the stimulation occurred, here again, the arm is lifting, so we can see that there is a definite change of the movement caused by the stimulation. So here the left hemisphere motor cortex is stimulated, and that was obviously an area that is related to the arm muscle. So how does this look like when we perform the stimulation with the device? So this is the basic control software, and here we can now set a stimulation session. Important is that we have a stimulation output trigger as well, so we can communicate with other devices like the amplifier, and here set the trigger of the stimulation event as a marker, and then, for example, we can trigger based on the stimulation pulses and see how the waveform of the EEG changes. Then here we can set now the standard configuration for the symptomatic stimulation. So here we have biphasic pulses with 500 microseconds phase duration, alternating polarity. We can start at the low current and then start the stimulation and observe the injected current feedback from the device. So we can see how strong is the stimulation current, and also here we have an impedance measurement, so we can see the stimulation impedance is low, because in that case that's a shortcut, and then we can start the stimulation when the impedance is low enough to inject the current. So the relationship of the impedance and the current is always, of course, that the higher the impedance, the higher is the voltage that is required to inject the defined current. So this is a constant current stimulator. So here you can, for example, set 5 milliamperes, and then based on that, you will have a related voltage. So here the resistance is very low, and you have constant current of 5 milliamperes, and of course the voltage is low. If the tissue impedance increases, the voltage will increase, and the maximum voltage that can be applied is 80 volts. So for example, if you want to set a current of 8 milliamperes, then for a 1 kilo ohm electrode you will get the 8 volts, and if you have, for example, a 10 kilo ohm electrode, you will reach the 80 volts. So usually 1 to 5 kilo ohm is a good impedance value for an electrode. Of course, the stimulation impedance is a bit lower because we are stimulating at a higher frequency. So here we are usually expecting around 1 kilo ohm. Okay, so now let's look at the language mapping experiment. So here, this is now a common task, a picture naming task. So the patient sees a sequence of pictures and has to express and name what they see. So here, for example, this is an egg, and in Japanese that means tamago. So now the patient is actually saying tamago. Christoph, is the sound on? Can you hear that? Or because I had problems setting the sound.
I hear it, yeah.
Okay, so we can hear tamago, and at the same time also we can see how the high gamma biomarker, so this is from electrophysiological mapping with corteq. So we can see here first the picture is observed, and then from the visual cortex it goes to the left frontal lobe, so where the Broca area or expressive language is located. And then after generating the word tamago, she actually tells us tamago without any problem. When we now stimulate into this expressive language area, then we can see that her response is much slower, and during the stimulation you can hear that with the buzzer sound. She is not able to talk, and afterwards she's still a bit slow. So this is a transient aphasia, and then she recovers after a few seconds and can talk again normally. Okay, and so now we had motor function and language function. It's also possible to induce visual illusions. So here, for example, we have performed together with the MIT and Gerwin Schalk an experiment where we wanted to understand how the phase perception works on the fusiform phase area. And for that purpose, the person or the patient here was stimulated here on the fusiform gyrus while looking at 4 different kind of objects or faces. So here this is now a box, and the patient looks at the pattern of the box, and here we saw the stimulation artifact, and this is already an after discharge that we talked about before. So here we are stimulating with 8 milliamperes into 1.5 millimeter electrode discs, and this is the maximum current that we can apply for this patient. So finally, Dr. Ogawa turned into an anime character, and interestingly, this phase illusion was also observed independent of the shape, round shape or rectangular shape, and color of the object. So this was a very consistent pattern. And when we just go a bit more to the occipital part, so a bit more posterior, then we can see that the visual illusion changes. So we have the same stimulation artifact, similar after discharge pattern. So here we have a similar visual illusion, but now the symptom is completely different. So the patient sees flashing rainbow colors on one field of view of the eye. So with that, we can now create a visual categorization map of, for example, different aspects of perception along the ventral temporal cortex. So, of course, the more we come to the occipital pole, the more the categories are like low-level perception, and the more we go towards the hippocampus on the fusiform gyrus, the more it's a high-level categorization, for example, for face recognition, eye, body parts, or place areas, or also sometimes we had a déjà vu symptom. So what is the effect of the stimulation clinically? So when we look at the meta-analysis of a few thousand patients already to understand how surgeries perform with and without the stimulation mapping, then we can see that the number of severe deficits after the surgery can be much reduced, and at the same time the gross total resection can actually be increased. This is very important because that means that surgeries can be performed more aggressively. So for brain tumor surgeries, you can remove more volume of the tumor, so the chances for longer life or progression-free life is good or better. And at the same time, the quality of life and the functional deficits are less. So this is a very strong argument to utilize the electrical stimulation, for example, during awake surgeries, of course also during the epilepsy monitoring. And the number of adverse events is a few percent, mainly related to seizures that are caused by the stimulation and maybe interrupt the surgery. So in general, the risk of inducing a seizure, which is not always a problem, of course, is around 10% of a stimulation session. So how does it look like? So here we have a stimulation experiment or mapping, and then there are some discharges, and these are then turning into a seizure immediately after the stimulation, and then you can see how the patient actually shows the stimulation related symptoms. Another stimulation technique are cortical evoked potential, so a single pulse electrical stimulation. The great benefit or good characteristic is that we are almost with no risk of inducing a seizure. So sometimes people are reporting that they can feel the stimulation, but it's not as, let's say, aggressive as the 50 Hertz stimulation. And here we don't have a symptomatic effect, so more or less the patient can remain in a resting state. And when you stimulate with a single pulse, for example, into the language area that you identified probably beforehand with electrical stimulation session or with high gamma mapping or with fMRI, then you can stimulate into that already annotated area and then identify related areas, for example, face motor or receptive language areas that are connected to this region. So this is a measure of connectivity when we see a very strong evoked potential on distant areas. And this technique has been introduced for functional connectivity measure by Riki Matsumoto in 2004. And since then, gradually, of course, it's growing more attention and interest. So the basic aspect is that we have a few components that are often characteristic and reoccurring for the stimulation response. So usually an N1 and N2 potential at around 30 to 70 milliseconds and 50 to 150 milliseconds. So these are like common components. There's also a P0 component that is also a good measure for connectivity. And with that, we can then understand how the responses are related to the stimulation target region. So here, for example, we measure on the motor cortex, so that's an oral motor pathway, and here we are measuring on the temporal lobe. So here in the posterior part of the temporal lobe, we can see evoked responses that are very likely related to the receptive language area. So let's again look at the stimulation protocol and the parameters. So for the stimulation here, we are utilizing a foot switch. So with that, for example, we can step on the foot switch, and by stepping off, we have an, let's say, emergency exit. So we can immediately stop the stimulation with an hardware interrupt. That is also a very powerful feature. For example, if you customize stimulation protocols for a study, and then if you observe that the patient has a symptom or a seizure, you can immediately step off. So here the stimulation settings are a bit different. So here we have monophasic and alternating stimulation with 300 microseconds, and here 5 milliamperes. So you can see that the charge density for this electrode is not a problem. And then we are repeating the single pulse stimulation at the pace of roughly 1.1 Hertz or 1 Hertz or 0.9 Hertz. So it's good to not use exactly 1 Hertz, because with 1 Hertz you're in phase with the mains frequency, the 50 or 60 Hertz, and by that you're kind of averaging the current phase of the interference in your evoked potential. If you have 1.1 Hertz or 0.9, then you're canceling out the interference by a constant phase shift. It's good to at least record around 15 to 20 pulses from each polarity. So here, if you have alternating polarity, you would need to record, let's say, 40 pulses in total, and then you have 20 positive and 20 negative. So how does that look like now? So if we here the maximum of 50 milliampere with 300 microseconds in this yellow stimulation target, then we can here observe, for example, responses already on the parietal lobe, and then we can see for different current intensities that we here get a different N1 potential with a stronger amplitude. Also, we can see a similar graduation in the neighboring channel. So we can see that the evoked responses grow with the stimulation intensity in the target area. Another aspect is, of course, the stimulation voltage. So when we stimulate here in this area with the macroelectrodes, then we can measure a voltage of around 10 volt that we need for here 12 milliampere stimulation. If we look at the so this is 2.7 millimeters disc, and this is a 1.5 millimeter disc. And here, when we are now stimulating at 3 milliamperes in the smaller disc, we actually have also a similar voltage of around 10 to 20 volts. So that means the voltage increases with the impedance of the electrode. That's very important. And the maximum voltage that we can apply is 80 volts with the g.tec Pro. Another aspect is, of course, what is the voltage not for the stimulator, but at the recording side. So when we, for example, record with the amplifier, the G high amp, then we need to be sure that we can actually measure the responses caused by the stimulation. And for that, we can test different configurations. So for example, here we have a stimulation electrode plus and minus, a recording electrode, and a ground. And for different scenarios, we can then measure the voltage at neighboring electrodes. So for example, in the setting C1, we are measuring here separated from the stimulation, and by that get a very low stimulation voltage on the recording side, so roughly 500 millivolts. So this is still saturated, but that's not a problem. And then when we, for example, record between the stimulation in the C4, then of course the stimulation voltage in the recording electrode gets much higher. So all of these configurations with the 1.5 millimeter discs are okay, and we can measure with the, let's say, macro electrodes without any problem responses from the stimulation. So some channels will be saturated, but the stimulation is valid. If you get to very high stimulation voltages and tiny electrodes, you have to be careful so that the stimulation voltage is not exceeding the supply voltage, of course, of the input stage of the amplifier, because with that you can then bypass the current out of the brain into the device. So this is very important to understand, and we can control that here, of course, with the standard electrodes. If you have a custom electrode that might require higher voltages or higher impedances, then of course we have to be careful and measure that beforehand. So how does the recording look now? So when we go into the G recorder, then we can see here with TTL input, the digital output of the eStim, and the input of the high amp, the vertical red lines are the triggers. And after each trigger, we can already see with the eye the evoked responses. So usually we have to record a CCP recording of at least with 1200 Hertz, preferably is 2400 or even higher. So the higher the sampling rate is, the more we can also resolve very early components and distinguish them from the stimulation artifact at the beginning. But important is also to understand here that these evoked responses are usually quite big, like a few hundred microvolts in the amplitude, and we can then average, let's say after 10 to 20 trials, already a good waveform that we can distinguish from baseline. So here we can see now responses in a matrix view. So we want to understand better how they're organized on the brain. So for that, we can open that in our offline toolbox, the GBS Analyze, together with the topographical montage that we created beforehand. And here we can now screen through all the stimulation pairs that we have set, for example, with the switching unit, to go through different cortical regions, and then for each stimulation pair, see the evoked responses on the distant locations. So here, for example, we are stimulating on the anterior part of the temporal lobe, on the ventral temporal cortex, and then we can measure, for example, even on the frontal cortex here, evoked responses. So we can now get a better understanding of what is in close proximity, like here, these electrodes. So everything that is in 1 to 2 centimeter distance, you have to be careful because of stimulation artifacts and volume conduction effects. But more distant electrodes are very good to measure connected areas with white matter tracts. What is also important, especially when we have a monophasic alternating stimulation, is to see how the waveform looks when we separate the positive and the positive and negative stimulation polarity. So basically here, what we can see is that in these distant locations, the waveform is exactly the same or almost the same, and the stimulation artifact is the opposite. So this makes us very confident that the evoked responses are coming from a physiological response and not maybe because of any tissue charge effect of the stimulation artifact. So this can be now also associated, for example, with electrophysiological biomarkers, so we can measure the high gamma activity, for example here, for face perception. So you can see here, whenever the person is looking at the face, we get here in red this very strong increase of the high gamma activity, so here in Z-scores, and then we can localize face-related areas. And then we can see how good the evoked potentials from the stimulation into the face network corresponds to the high gamma activation. So here in red and in blue and in orange, we can see the lift of the high gamma face perception, the face-related evoked potential, and also the stimulation evoked potential. And they correlate nicely when we then look at the pattern of the activation of the electrophysiological responses. Another scenario is to perform, for example, intraoperative mapping by means of high gamma mapping of a listening task that can be even done under mild sedation, like a BIS of 80 to 85. And then we can see the activation profile from the listening and stimulate into this activated area on the temporal lobe and measure the evoked responses here on the frontal lobe. So with that, you can get a connection of your language network and confirm that with the electrical stimulation. So now if we want to combine that, for example, with fiber tracts from tractography, we can utilize the intracranial EEG montage creator, for example, to import free surfer reconstruction of the cortex with the pacillation and the white matter information, and then run, for example, Dracula along with free surfer. So for that we need a T1 weighted MRI and then an echoplanar MRI scan, so a DTI scan. And then when both the free surfer recon and the free surfer Dracula pipeline are done, we can import the output in the montage creator, and then add the fiber tracts as individual surfaces. So for each main fiber tract, so the output of Dracula performs a probabilistic tractography that is actually utilizing the anatomical landmarks from the free surfer reconstruction. And here we can then add the main fiber paths, so you will get 42 main fiber pathways that you can then use as individual layers and stack to show it together with the mapping information. So when we look at, for example, here, a mapping result from the high gamma mapping, from a language case where we have done a picture naming mapping, then we can superimpose that with the aquate fasciculus and the uncinate fasciculus, and then stimulate into the active region and measure the evoked responses along the temporal cortex to see how they are connected. And this is not only possible, for example, for the language network, this also works when you want to understand how the epilepsy spreads in the brain. So with this case, together with Dr. Kamada, he performed a study to understand better how the epilepsy network can be disconnected by means of measuring the seizure onset zone and the spreading of the evoked potential when stimulating into the seizure onset zone. So here, for example, we have a case where we have a bilateral interictal spikes, both on the left and right frontal lobe. And the earlier onset is actually on the right hemisphere here. So now if we perform with our CSEP toolbox in HISUS, in MATLAB and Simulink, CCP mapping, then we can see here in yellow the stimulation entry point. And here is the stimulation artifact where you can see the alternating polarity. And here in the vectorscope you can see how the evoked responses are looking on average. Of course, they are not really changing anymore because the signal to noise ratio is very strong. And then we can see in red the RMS value of the evoked responses. We can also see here on the contralateral hemisphere even the stimulation response that is visible through the interhemispheric connection. So for this case, the idea was then to cut this connection by corpus callosotomy. And for this, we wanted to understand how these two hemispheres are connected. And there's already a good study that shows how the waveform of the CCP actually correlates to the path length and also the FA value or the propagation velocity in the fibers. And important to understand is that, for example, with the Dracula output, we cannot nicely get these crossing fibers. So for this, we have to choose an alternative technique. So here, the unscented Kalman filter, a 2-tensor tractography, gives also the possibility to identify crossing fibers. And with that, we can now define some regions of interests where we want to get the fibers that are going from our stimulation start point through the corpus callosum into the measured endpoints where we saw the CCP. And interestingly is now that we can, during the surgery, perform CCP monitoring. So here you can see at the beginning of the surgery the connectivity from one hemisphere to the other. And then partly the corpus callosum gets resected. And when we now reach the anterior part, the genu, we can actually see that the evoked responses are then diminishing. So here, okay, my video just turned off. I have to restart PowerPoint. Okay, there we go. So here we can see that now after like a few few trials, we can see how the noise diminishes, and then we know, okay, there is no remaining evoked potential anymore. So this was the proof of the disconnection. I will jump over that. And then there's also a paper where now 14 cases have been treated with the combined CCEP and tractography monitoring. And in order to speed up the CCEP, we can now utilize the switching unit. So here, for example, you submit a table of all the stimulation pairs that you would like to stimulate in a sequence. And then you can go from one side to the other and route to the stimulation, stimulate, let's say, 20 times and go to the next one. And with that, you can have then, for example, a whole brain network screening in less than an hour. So here we can see the stimulation pairs, so the stim plus and stim minus in red and blue, and then the connected areas in red bubbles, which is the RMS value of the evoked responses here in the middle. So we can see, depending on the stimulation area, we get good or less CCEPs. So here, for example, that was in silent area. Now we are switching here on the ventral temporal cortex, and we can see there are very strong connected areas, and we can see also these distant patterns that are interconnecting different cortical regions. Okay, so yeah, this is basically an introduction how to conduct the brain mapping with cortical stimulation, also to perform a measure of connectivity with single pulse stimulation, and how to identify how these related areas are interconnected with tractography. Thank you.
Thank you very much for the impressive presentation, and we have a couple of questions. Serap is asking a general one. What's the difference between closed loop stimulation and neurofeedback?
Well, neurofeedback is something that you give to a person to understand the effect of, for example, brain activation. So this is not necessarily with electrical current, but it could be. And if you perform a neuromodulation experiment, it's not always a feedback. So it can also happen that you do, for example, neurostimulation, let's say for suppressing seizures. So it wouldn't be an actual feedback, but it would be a suppression or termination of an event that would happen. And also if you, for example, suppress a tremor, then you will, based, for example, on an beta burst that you would measure with the electrodes, target the stimulation and trigger the stimulation, but that would not give a feedback in a sense to change the behavior of the beta power for the patient. It would just treat that. So neuromodulation could be more autonomous, where feedback would involve the patient.
So the very easy explanation is neuromodulation applies electrical stimulation, magnetic stimulation, so you are stimulating into the brain or periphery. And for neurofeedback, you are changing the brain by itself, so you don't provide stimulation, it's self-regulation. That's a very important difference. So it's only the closed loop system with neuromodulation with stimulation. Another question is, what's the epilepsy hotspot?
So there's the epileptogenic zone, and inside that there's usually a focus like the seizure onset zone. And in our case here, the hotspot was the seizure onset zone, where we stimulated the earliest occurrence of the epilepsy waveform.
Then somebody's asking what's actually the strength of the language mapping when you're doing it with CortiQ. So why is it so important to provide language mapping?
So of course, language function is one key aspect in the quality of life. And so for interrupting the ability to speak, we want to, by that, better understand which parts have to be preserved. And there are like now a few techniques. So what you can do is you can of course do the electrical stimulation during a wake surgery, where you talk to the patient or perform a picture naming, and then before resecting the tissue, stimulate into the tissue. And then when you experience like a speech arrest, then you would stop, if possible. Of course, it's a trade-off. If that is already tissue that has to be resected, to go another path. And so there are some limitations, of course. You have to do that under awake conditions to test language. And for example, if you have the possibility also to conduct language mapping with CCP after identifying the entrance point, you could even preserve language fibers. This is still something that is not state of the art up to now, and would tremendously improve surgical outcome if you are also able to measure language related fibers during the surgery. So for example, under general anesthesia, you can already measure motor fibers by motor evoked potentials and SEPs, but with language that is still only possible with the wake surgery. And here the high gamma mapping and the ECS and the CCAPs are a very powerful tool.
So Joy has a very important question. What happens if you accidentally stimulate the wrong brain area?
So if the current intensity is not too high, then usually nothing happens. Maybe you elicit a feeling like an auditory illusion or a visual illusion or some kind of sensation. If there is like also a peripheral nerve involved, it could cause pain. If the seizure, if the stimulation current is too high, of course you have to be careful to not induce a seizure, but that applies in general for stimulating the brain.
But actually the factor can be dramatic. There was, for example, a manufacturer in the US, and they had a switching unit, and they had a firmware mistake in the switching unit. So they exchanged channel numbers, and then they did the mapping, the eloquent cortex mapping. And they assumed that functional areas are at certain position. For example, the finger region is at electrode 17, but by exchanging channel numbers, you are resecting the wrong area of the brain because you assume the finger region is somewhere else, and so on. So it has a dramatic effect for neurosurgery if you are applying the current to the wrong brain area.
This is a general problem because, of course, you have to know where you are and what you do. So it's not a problem to stimulate the brain with a low current accidentally when you know that you did that. If you don't know that, it's a big problem. And also, there's like in clinical setups, you have to understand if you connect 100, 200 electrodes to head boxes, this is all done manually. And this is a repetitive task. It's a very simple task, but every single mistake that happens in the electrode connection has severe consequences on the outcome. So all the like steps that are interdisciplinary, demanding from many people, the patient is involved, surgeons are involved, neurologists, psychologists, everything is useless if the first step, the cable connection, is wrong.
So thank you very much, Kapi, for the nice presentation.